Announcements are now complete, and without much further ado, I would genuinely like to welcome our first speaker this morning, Dr. Kathleen Thiessen. Dr. Kathleen Thiessen is a senior scientist with Scenes Oak Ridge Incorporated Center for Risk Analysis. She holds a BA in biology and chemistry from Covenant College and a Ph.D. degree in genetics from the University of Tennessee Oak Ridge Graduate School of Biomedical Sciences. As a risk assessment professional, she is experienced in the evaluation of exposure, doses, and risks to human health from trace level of contaminants in the environment, and in the use of uncertainty analysis for environmental and health risk assessment. She was one of the co-authors of the National Research Council's 2006 report on fluoride exposure and toxicology. Please give a warm Academy welcome to our first presenter, Kathleen Thiessen.
Okay, as advertised, the disclaimer: I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. I want to thank you for the honor of coming here for this conference. It's been an interesting several years studying this subject, and I know it has had interest to many of you in here. I'll say up front, some of what I tell you will be old news to some of you, but it may not be for everybody, so that's why I'll try to fill in the details on that. Okay, a risk assessment perspective on fluoride exposure and toxicity. Risk assessment generally has to do with quantifying the amount of a hazard of some sort. Usually we use it for hazards or bad things. The risk of getting on an airplane to fly to Minneapolis for this meeting, for instance, or how much of an earthquake do you need to have your nuclear power plant prepared to withstand. This is all in the general area of risk assessment. In environmental risk assessment, we're usually dealing with contaminants, chemicals, or radionuclides, and we're looking at exposure and the amount of hazard that poses and what are safe levels in the environment. For fluoride, there is a context. It's not just the next chemical on the list, but we are in this situation where it is knowingly and purposefully added to the drinking water in much of our country and several other countries. Community water fluoridation is one of the 10 great public health achievements of the 20th century, according to the CDC. But the CDC also tells us that fluoride's predominant effect is post-eruptive and topical. I have never had a dentist tell me that every time I drink water, I should swish it around my mouth first before I swallow it. So there's little or no topical exposure of your teeth to drinking water. And many of us had mothers who would not have permitted that kind of activity with our drinking water. Last year, about a year and a half, almost a year and a half ago now, there was a proposed new recommendation from CDC and Health and Human Services to lower the recommended fluoride concentration in drinking water. At the same time, CDC says on their website, it's not our task to determine the safety of fluoride, but you also have the CDC and the ADA telling you that water fluoridation is beneficial and safe for everybody. So let's take a look at some of that. Just by way of history, sodium fluoride is a well-known insecticide and ingredient in many roach powders. This is from a chemical manual in 1928. The American Medical Association in 1965 said that they were not prepared to state that no harm will be done to any person by water fluoridation. We had a very fine article almost 10 years ago now by Doug Cross and Bob Carton. The ethical validity of fluoridation policy does not stand up to scrutiny relative to the Nuremberg Code and other codes of medical ethics. Fluoride is a drug, to cite another paper, perhaps the most widely used medicine in history. Fluoride toothpaste, you look it up, it's an over-the-counter drug. It's got all the drug facts and warnings on the back of the box. Fluoride drops and things like that are a prescription drug. To get the smallest amount of prescribed fluoride, that's 0.25 milligrams, you can get that in 1 cup of fluoridated water in many cities in this country without a prescription, without anybody monitoring it for effectiveness, correct dose for the size of person, side effects, anything of that sort. Sources of fluoride exposure, there are 2 types that we look at: systemic, which refers to ingested or inhaled fluoride, and topical, which is directly applied to the teeth. That would be toothpaste, rinses, varnishes, those sorts of things. Systemic fluoride, water is a major source, food including tea, toothpaste and other dental products if they're swallowed. Drugs, some drugs and some anesthetics produce fluoride in the body. Occupational exposure in certain industries, pesticide residues, air pollution. Fluoridated tap water is typically between a half and nearly all, 50 to 90 something percent of fluoride intake for people in the United States. This is material from the National Research Council's report on, let's see, okay, the graph on the left is for people who consume an average amount of tap water. The one on the right is for people who consume high amounts of tap water, not necessarily the highest, but high. And you see for people who consume an average amount of community water, for the older children and adults, that's roughly half of their fluoride intake. For some of the youngest ones, that can be much more. The groups with high tap water consumption that are very easily distinguished from the general population, within the general population: infants fed formula prepared with tap water, athletes, workers, military personnel, anybody with a lot of activity, physical activity. The water requirements are obviously higher. People with certain medical conditions, diabetes mellitus, diabetes insipidus, those can be or are associated with high to extremely high intakes of water. Now that CDC recommendation that came out last year was based on an assessment by the Environmental Protection Agency that was supposed to help them decide what was a safe level, okay? And I'll talk more about that later. But that assessment considered that they considered a level of 0.05 milligrams per kilogram per day intake as desirable, so they didn't look at anything that got close to that or below that. They said a safe level of intake was 0.08 milligrams per kilogram per day. They dropped the very youngest children out of the assessment. We can't have people in the assessment who are already exceeding the safe level. And they looked only at the average consumers. They obviously paid no attention to their high consumers. This is an estimate, just a plot of the range, the distribution of fluoride intake in infants less than 1 year old. This assumes 1 milligram per liter of fluoride in the drinking water. It's based on a summary of water intakes that EPA published in 2004. You'll see that infants in this country, and this is based on several thousand, I don't remember exactly how many, but they fall into 3 groups. This is not one nice, neat bell curve. This is 3 bell curves. For those of you not familiar with a log scale, think dollars, dimes, pennies, tenth of a penny. Just every one of these, the intake is 10 times higher. These are infants who are breastfed or given ready-to-feed formula. These are infants whose formula is prepared with tap water. These are intermediate. Now, EPA didn't categorize these. They just lumped them all into one, and they don't actually produce this graph, and they may not realize that there's 3 parts to their distribution. But we have the software to do this, and we did this. But based on the information available, these would be the formula-fed children, the breastfed children, and children with an intermediate exposure, for instance, those who are being transitioned to cereal and baby food and such. The vertical lines, that's the 0.05 to 0.07 milligrams per kilogram per day that has long been labeled the optimal fluoride intake. Okay. EPA's recent material and CDC says 0.05 is the optimal and 0.08 is the cutoff for a safe level. The other thing to notice here is you've got about a factor of 100, 200 between the lowest intakes and the highest intakes. Okay? This is just from drinking water. This does not include any other sources of fluoride exposure, anything in the formula preparation or in baby food or anything else. And this is partly why the American Dental Association and the CDC have very quietly said, well, if you think dental fluorosis might be a problem, use bottled water to make the formula with. Okay? In other contexts, they tell you that bottled water is made from somebody else's tap and probably has fluoride in it anyway. But that's this situation. Let's look first at the benefits. Because fluoride is purposefully added to the water supposedly to produce a benefit, I have found that before you can get anywhere talking about the hazards, first you have to address the benefits, because that's what the population thinks of first. Get to right. Okay. This is one more example of the range of fluoride intake before I talk about benefits. Okay. This is from the Iowa study, which has been following individual intakes of fluoride by several hundred children for a lot of years now. And this is the fluoride intake. This is the age up to about 8.5 years. Remember, 0.05 is supposedly the desirable intake. 0.08 is the safe level, according to EPA recently. The Iowa study found intakes in the youngest children up above 0.2 milligrams per kilogram per day, and one child over here at about age 7. The averages are about 0.05 for the youngest and 0.2 or 3, 0.02 or 0.03 over here. Each of those little marks represents an individual child. But you see the great range in intake among children, and here they have looked at all sources as best as they could estimate them. Okay, with respect to benefits, this is the same study. This is the graph I just showed you showing the range of fluoride intakes. One of these lines is the children who have no fluorosis and no caries. That's the same group that was in this last graph. We also have a line for the children with caries but no fluorosis, children with fluorosis but no caries, and children with both. Now, you notice the great range of fluoride intake in the one group. They didn't give us the distributions for the other 3, but they're going to be roughly that size. Show us the separation between these. There's essentially no difference in any of these groups. This was a paper I did not expect to see published from the Iowa group, and to the best of my knowledge, they don't cite it in their own work. But they said in this study, they reported no association between fluoride intake and caries experience. The caries rates, that is the percentage of children with or without caries at ages 5 and 9, were similar for all levels of fluoride intake. The authors state that the benefits of fluoride are mostly topical, and that their findings suggest that achieving a caries-free status may have relatively little to do with fluoride intake. Okay, this is in the published paper from the one study that has looked at individual fluoride intakes and the outcomes in terms of caries and fluorosis. Most of the children with caries had relatively few decayed or filled surfaces. The main conclusion was that given the overlap among the caries fluorosis groups, that in terms of mean intake, and given the extreme variability in intakes within a group, formally recommending an optimal fluoride intake is problematic, in their words. In other words, you can't, from their data, define an optimal fluoride intake in terms of caries prevention, and there's no association with the caries intake, the caries status, and the fluoride intake. So to put it another way, the amount of fluoride intake did not correlate with a child having caries or not having caries. There was no caries reducing effect from fluoride intake. There is an increased risk of dental fluorosis with increased fluoride intake. I'll come back to this study with respect to dental fluorosis in a few minutes. Okay, this is an older study. This is from a very large American data set, close to 19,000 children who had lived in a single residence all their lives, ages 15 to 17. This is the DMFS status, decayed, missing, filled surfaces. This is the water concentration, fluoride concentration in the water at those residences. So this is for a range of ages. If you picked a single age, you might, for some, I think you would see bigger differences. So between the low fluoride group and the so-called optimal fluoride group at 0.7 to 1.2 milligrams per liter in the drinking water, this has been the recommendation for several decades. The new recommendation last year was to lower it all to 0.7. I don't think most of the country has made any changes yet, but some have. Anyway, the difference between the low fluoride and the optimal fluoride is 18%. In absolute terms, this is 1/2 of a tooth surface. So you've got 1/2 fewer decayed tooth surfaces in these children. The probable explanation that was not accounted for in this study and has not been accounted for in any studies that I'm aware of is the effect of fluoride intake to delay the eruption of the permanent teeth. This has been known since the 1940s. It was stated in the 1950s in a National Research Council report that the longer the time the tooth is exposed to the world, carcinogenic substances, food, all this, the longer it's exposed, the higher the likelihood of caries. So obviously, if you delay the eruption of the permanent teeth by a year or two, you've got teeth that have been exposed for a shorter time than when you're comparing it with other people of the same age. There's one statistical analysis that indicates that this delay is probably sufficient to explain the observed differences between fluoridated and non-fluoridated areas. But note also that if you get, in this particular study, with a little bit higher fluoride concentration, the mean DMFS is back up higher than these two. Okay? And actually, if you look at it with some idea of the statistics going on, there's no statistical difference here. It's just not. This is a graph of, it's a hypothetical graph. This is not from actual data of what happens with delayed tooth eruption. This is the deciduous teeth. This is the permanent teeth. The solid lines are the the normal situation, the dotted lines are with delayed eruption. This paper actually had to do with delayed eruption because of malnutrition. It does not discuss fluoride, but the effect of delay is going to be the same, whatever the cause of the delay. But in deciduous teeth, you get a rise in the caries and then a fall in the caries as the deciduous teeth are lost. With permanent teeth, you just get a rise. Okay, so if the loss of the deciduous teeth is delayed and the eruption of the permanent teeth is delayed, you look at these children at age 7. In this hypothetical example, you've got a rate of decayed missing filled teeth of about 6 per child in the ones with delayed eruption compared to about 3 in the normal children. So you say, whoops, this delay in tooth eruption, or whatever the cause is, it's causing worse teeth in the baby teeth, in the deciduous teeth. You look over here at age 12, the normal situation, these kids are already about 5 decayed teeth or something. The ones with delayed are about half of that, so you say better teeth in the 12-year-olds, okay? And it's just a matter of looking at a cross-section at a given age when the curves are offset. If you get out here to older ages, this one's going to catch up, and you've got no ultimate effect. There are several of us who have been trying to find data on tooth eruption, how many teeth at a given age and so forth in fluoridated and non-fluoridated situations or with and without a significant fluoride intake. Those data are not published. They have not been published in several decades, and I think there's a reason why they haven't been published. They exist. The Iowa study has this information. They participated in a study on genetic aspects of timing of tooth eruption. So, yeah, the data are there. But that is the likely explanation for what apparent benefit is seen. And until somebody does a study that accounts for delayed tooth eruption and still shows a benefit, I think this is the likely explanation. Okay, this is the same study. This is the same study I showed a minute ago with that 18% reduction in DMFS. These are the curves, the distribution. These are the ones with 0 decayed missing fill surfaces, 1 to 5, 6 to 10, 11 to 20, greater than 20. Water fluoride level, you can obviously distinguish the great amount of room between the people with no fluoride and the people with a high fluoride in their water. All right? You see the big difference in the curves? There is no statistical difference here, okay? Not by any means. And these, if you had the confidence limits, these things are probably pretty broad distributions. There's no statistical difference. Whatever is causing some people to have lots of caries, it's independent of what the water fluoride is. I have encountered a lot of people from this group. Journalists, for instance, seem to have many representatives in this group, and they're convinced that if they'd had fluoride, they would have moved up to here somewhere. But the data don't show that. And this is from close to 20,000 children. Okay. Just a couple other comparisons of what's going on. If you look at the countries that have fluoridated, at least to some extent, Ireland, I think, is roughly 70%. The U.S. is about 2/3 now. And you look at the decayed missing filled teeth in 12-year-olds. These are data from the World Health Organization. I pulled them off the internet a few years ago. They're probably still there. Other people have published the same kinds of graphs. You see this wonderful decline in caries experience in the fluoridated countries. you also see this same decline in all these non-fluoridated countries. Okay? So whatever is causing the decline, it's probably not the fluoride, because you get the same decline in countries that are not fluoridated and countries that are fluoridated. One other thing to note from this graph is if you want to be careful about which data you select, you can show almost anything you want. This is a graph first put together by John Colquhoun in a 1997 paper, and then Dr. Hardy Leimbach in Toronto added some of these labels. This is New Zealand, and it represents most of the children in the country because of school-based dental clinics. There's 1930, 40, 50, up to 1990. So this is what's going on with dental health. The introduction of penicillin, vitamin D in milk, artificial sweeteners, fluoridated water, fluoridated toothpaste, xylitol. A couple of things that aren't shown back here is the introduction and widespread use of refrigeration so that fruits and vegetables became available essentially all year. There's a 1950s National Research Council report that reviewed a lot of the information available on indigenous peoples, native tribes, whatever you like to call them, and how the oral health was always very good. You get a few broken teeth when somebody got old, but otherwise their teeth were pretty good until they started having access to a civilized diet. Once they got flour, sugar, dental health went down. And there's a paper that shows the same effect for immigrant children to the U.S., the ones coming from subsistence agricultural situations where all they had was produce, very good teeth, standard of living goes up, they can afford sugar, dental health goes down. So obviously there's a lot of things going on. Fluoride has had really little or no contribution on this. This is a state-by-state comparison of the percentage of the whole population that's fluoridated and the percentage of children with excellent or good teeth as reported by their parents. So no dentists even involved in this study, just the parents. This is from the Health Resources and Services Administration, so it's one of our lesser-known government agencies. Percentage of the whole population fluoridated, that data comes from the CDC. It's adjusted for the percentage of a population that actually uses municipal water as opposed to well water or something. This is Washington, D.C. Tennessee is one of these. I didn't look up Minnesota. But you see, again, the great effect as you increase fluoridation, you increase the people's health, their dental health. It improves, right? This is no effect. The Utah and Hawaii over here with very little fluoridation at the time, these data are several years old, they've got the same dental health in children as the highly fluoridated states. And this, you see a fair amount of scatter, so there's other things going on. This is the same graph that I just showed you. Percentage of population fluoridated, children with excellent or very good teeth. This is the children with excellent or very good teeth. This is a percentage of children in poverty. Now you see an effect. This is a much stronger effect. Again, there's a lot of scatter. If you divide these children up by socioeconomic level, these are children whose families are at least 4 times above the poverty level. These are children below the poverty level. In either group, you see no substantial effect. You definitely do not see children in this, the low economic status children, you see no beneficial effect of fluoride of moving them up to here. You do see another fine opportunity to very carefully select your data. You know, if you get this state over here with low fluoride and you compare to one of these, but that's artifactual. You've got a lot of other things going on. The scatter is the distance either side of that average line is probably related to economics and some other things. But the point is that children with a higher economic level, their teeth are going to be generally much better than the poorer children. And that stays the same regardless of fluoridation. Children with excellent or very good teeth, once again, this with a percentage of the population fluoridated. So the one thing that fluoride in the water is supposed to do, it doesn't do, according to these data. But if you look at some other endpoints, these are older adults who have lost all their teeth. The more fluoride, the likelier that they've lost all their teeth. The health ranking goes down, the prevalence of obesity goes up. I don't have graphs for it, but the likelihood of preterm birth goes up. The likelihood of violent crime goes up. And some of these are more closely related, better related to economic things than they are to fluoridation. But simply the fact that fluoridation shows no effect for the one thing it should do, and a lot of effect or some effect in the wrong direction for things that it's not supposed to have any effect on, that we need to worry about a little bit. Okay, known or reasonably anticipated adverse health effects of fluoride exposure. The language known or reasonably anticipated comes from EPA's definition of a maximum contaminant level goal, which is supposed to be set at a level at which no known or anticipated adverse effect on the health of persons occurs, and which allows an adequate margin of safety. Okay? This is not a complete list. The information is better for some effects than for others. Something that's important to remember, that the lack of really good studies showing evidence of an adverse effect is not the same as having really good studies showing the absence of an effect. We do not have really good studies showing the absence of an effect. We have studies of varying quality, some of them quite good actually, that do show an adverse effect. And in general, that do show increased risks of various effects with increasing fluoride intake, including the ranges that you expect to encounter in fluoridated situations. And we'll look at some of those briefly. Okay. This is, once again, the same study of close to 20,000 children. This is the percentage of children with no caries experience compared to water fluoride level. It's roughly 50-something% regardless of the fluoride level. You do see a very nice dose-response effect both for fluorosis in the red, incidence of fluorosis, and for severity of fluorosis in the green. Very good dose-response effect. You have to actually take the data from this paper and do your own graph, though they didn't offer to tell you this. Dental fluorosis, I know a lot of you are familiar with it, and David has showed you numerous pictures. These are pictures that Hardy let me have to show. This is what the American Dental Association and the Centers for Disease Control tell us this is what they're trying to prevent when they suggest that you make formula just with bottled water. On the other hand, it's just a cosmetic effect, so they're not going to worry about it very much. This is mild on the left, moderate on the right. It gets worse than that. The psychological impact on an individual obviously can be large. And we know that intuitively. There's not been a lot of study of it. Cosmetic treatment is expensive. It has to be repeated. If dental fluorosis is severe enough, there's an increased susceptibility to caries. The National Research Council, including with some dentists on the panel, considered severe fluorosis to be enough of an adverse effect because there's this increased likelihood of caries in the severe dental fluorosis. The presence of dental fluorosis indicates that a person had high exposure during early childhood. which might or might not have continued through adulthood. It may also indicate individual susceptibility to effects of fluoride, and there's not been enough study on that. Several studies in other countries have shown an association between dental fluorosis and increased risk of other adverse health effects, including thyroid disease, lowered IQ, bone fracture. These studies have not been done in the U.S., but basically the higher the prevalence of fluorosis or the more severe the fluorosis, the more likely that one of these other things exists also. This is a Mexican study, dental fluorosis and fracture history. This is categorized by the level of dental fluorosis from normal teeth to severe fluorosis. Fracture history, percentage of people in the study who had experienced a fracture, children in blue, adults in red. For this situation, exposures probably continued not just in early childhood but on into adulthood. So these are people who've had, by this point, have had a lot of fluoride exposure. But in general, the more severe the fluorosis of the individual, the more likely that that individual has had a bone fracture. Okay. I think we skipped one here. Yeah. Okay, this is from the Centers for Disease Control in 2010. The blue columns are the 1980s data, and that's the one I've been showing you other things from, that set of 20,000 children. The green are more recent data from 1999 to 2004. This is level of dental fluorosis. Unaffected has gone from 47% to about 40%. The higher forms have increased, and the main thing that's happened in this time period is that much more of our country has fluoridated water. There's been an effort to decrease swallowing of toothpaste. There's been an effort to decrease fluoride content in infant formula. So the main thing is that more cities have fluoridated, and fluoride in anything, of course, that's made with the tap water, processed food. So there's just generally this higher exposure to fluoride. And so you've got a shift in the distribution over toward more severe. Now remember, the optimal level in fluoride of fluoride in drinking water of 0.7 to 1.2 that was set years ago was set to keep total fluorosis at or below 10%. And severe fluorosis shouldn't happen at all. Now what we've got is 40% of children with fluorosis. That's not even counting the questionable ones. Almost 4% have severe fluorosis, and this is just this one study that did not look at fluoride levels in the water for these children. So the standards, the recommendations for fluoride in drinking water have been too high by their own criteria for quite some time. This is a study from Canada. They got bone samples from people getting hip replacements in Toronto, which had been fluoridated 35 or 6 years at that point, and Montreal, which was not fluoridated. This is the fluoride content in the bone of these individuals. Most of these were diagnosed with osteoarthritis. They did not take exposure histories for these patients. Hardy Lineback was involved peripherally in this study. He didn't get a lot of influence. He tried to get them to get exposure histories, and they didn't do it. The important thing is that for adults, these are average age in both groups is around 65 or 70. For the individuals who had been exposed to fluoride in Toronto for approximately 36 years at this point, starting as adults, you've already got 2 individuals up in the range reported with skeletal fluorosis, some that are very close, and we don't know enough about the actual medical situations for these individuals. Montreal, that's not fluoridated, isn't all that far behind. But you expect if you add another few years of fluoride exposure that some of these are going to be well up there. United States, this is a study out of Utah in 1992. This is women on the left and men on the right. These are comparing the fluoridated cities with the open squares to non-fluoridated cities. The men, you see a clear difference in the hip fracture rate. And again, this is not very many years of fluoridation. It's for exposures that started as adults. And you get an increase. This is a statistically significant increase in the exposure rates. Now women, you've got an increase in the younger women. These started an exposure to fluoride before menopause, when the bones were still taking up fluoride. After menopause, women don't do so well at taking up fluoride. The men do. But you see a statistically significant increase in likelihood of hip fracture for women exposed before menopause. This is the only study I'm aware of so far that has looked at aged exposure for this kind of endpoint. So increased risk of bone fracture from exposure to fluoride. Decreased IQ. These are two graphs from a Chinese study. This is out of the National Research Council's report. The blue, the solid lines are the low fluoride town. The dotted lines are a high fluoride town. This is in China. These are children. The graph, the distribution of the IQ shifts to the left. You don't want it to go in that direction. You've got fewer children here in the bright category. You've got more children down here in the category of needing special education. This is one, there were only about a half a dozen studies available in English at the time that the National Research Council did its report. Paul Conant, in his book a couple of years ago, looked at 20-something studies on IQ. The Harvard study that was published very recently by Anna Troy and Philippe Grandjean and a couple of others looked at more like 30 studies, including this one. And overall, there's a consistent difference. There's only one study, I think, that was very slightly in the other direction. But regardless of what those fluoride levels in the water are, some of them are around in the range we have in this country, and some of them are a bit higher. But the group with the higher fluoride exposure always had the lower IQ distribution, with the average shifted over about a half a standard deviation. The earlier press release out of Harvard said about a half an IQ point. That's wrong. It's half of a standard deviation, so more typically about 7 IQ points. But again, the point is that you've got fewer people at the high end, many more people at the low end for the IQ distributions. And there are some other endpoints that also show a shift in the distribution. The mean or the median may not shift much, but you have more people in the low end. For instance, the age of onset of puberty in girls, we looked at that in the NRC report, all of 2 papers, one of them from the United States in the 1950s, the Kingston-Newburgh study. In the fluoridated town, girls they reached puberty a few months younger than the girls in the low fluoride town. So again, a shift in the distribution, which may indicate susceptible subpopulations. There's also, for many of these, if you increase the fluoride concentration enough, that distribution shifts a whole lot more. So this is obviously a concern, and this is real. There's a paper from several years ago already that put fluoride in the list of emerging neurotoxins. These are children who were exposed all their lives. Okay, thyroid effects. Well, I understand we'll hear more about thyroid later, not all necessarily in the context of fluoride. But the general finding from a lot of studies, most of these have not been really detailed or thorough studies, not as detailed as we would like, but they're all consistent. The higher the fluoride intake, the lower the thyroid function. Increased prevalence of goiter in this slide, elevated TSH, thyroid stimulating hormone levels in this graph. This is children in towns in South Africa. 5 of these towns had what they labeled as inadequate nutrition, or a high prevalence of undernutrition. And 1 town with adequate nutrition, essentially no effect. These are typically, these are low, very low fluoride, at or below what we have in this country. These are right around a little bit higher. But you get a nice linear dose response. The higher the fluoride in the drinking water, the more likely to have goiter. This study is from Ukraine in a population with water concentration of about 1 and about 2.5 TSH level. Until recently, the upper end of normal for TSH was around 4.5 or 5. There is a shift to now say that 2.5. You need to be considering low thyroid function. Doctors in this country, my understanding, is still vary on this. But clearly, again, from these 2 situations, the people with the higher fluoride in their drinking water clearly had a higher TSH, which means lower thyroid function. These individuals are on the borderline of what would now be considered low thyroid function. There's a lot of material that says that that fluoride replaces iodine in the thyroid, all the biochemistry. That is probably not the case. Fluoride ion is much smaller than the iodide ion. What's probably happening is that fluoride is inhibiting enzymes at several steps in the thyroid metabolism, for instance, the deiodinases that are essential to making active thyroid hormone out of the precursor. So there's definitely more work to be done there. Okay. Osteosarcoma. This is another one that has been in the news a little bit. This is Elisa Bassen's 2001 dissertation. It was a 2006 paper in a cancer journal. The black symbols are children whose exposure was above the so-called recommended levels, and the gray ones, the children between 30 and 99% of the recommended levels, and this is in comparison to the lowest, the below 30. This is exposure at different ages, and what you see is, this is boys, a clearly elevated risk by a factor of 6 or 8, 4 to 6 or 8, for children exposed during late childhood before puberty. There's an elevated risk of osteosarcoma, statistically significantly elevated risk. This is still the only study that has looked at age-specific exposure, which means if you take all of the other studies, some of which found an effect and some of which didn't, but they didn't look at age, at exposure, you cannot say that those are negative studies, because now we know that there is at least a possibility of an age dependence. And you do have age dependence with a number of other things. This is not a surprise or not a we don't believe you thing. There has been a more recent study out of the same group in Harvard. This is a paper by Kim et al. That came out last year, where this one was published in a cancer journal. The Kim study was published in a dental journal, even though there was no dentistry in the article. That article had a very poor set of controls. They were about more than twice the age of the cases. Osteosarcoma, it's a bone cancer. It often results in loss of the limb. It can result in death, but osteosarcoma is a disease of children or very old people, typically. Two peaks in the distribution. So Kim's study had a set of controls that wasn't even relevant, that were in the hospital for a different kind of bone cancer without considering the possibility that fluoride might cause other kinds of bone cancer also. But what they did find, they took fluoride samples, they took bone samples at the time of the surgery and calculated the fluoride concentrations, measured the fluoride concentrations in those, and said, oh, well, they're about the same, so it can't be that. But most of you are probably familiar enough with cancer development. This is an event that initiates a cancer, and 5, 10, 15, 20 years later, the cancer shows up. So if you measure a fluoride concentration out here, you've got this whole length of exposure. It tells you nothing about what happened at the time it was initiated. But what it does show in that study, in cases that were much younger than the controls but had about equal fluoride concentrations, is that the cases probably had 2 or 3 times higher fluoride exposure in order to have the same concentrations of fluoride at a younger age. So that study did not look at age-specific exposure and specifically says that. So if you see something and there are things out there that say that the Kim study refutes the Basson study, it does not. If anything, it supports it. Okay, another thing that is often associated with fluoride in drinking water specifically is increased lead in the blood of children, and this has to do with the use of silicofluorides as the fluoridating agent. It's a byproduct of phosphate fertilizer manufacture. It contains impurities, which has you adding these impurities to drinking water, even though the ideal for these things in drinking water is 0. Reacts with chloramines. Chloramines are used in some systems as a disinfectant instead of chlorine. The hope is to reduce the chloroform sorts of exposures. But chloramines and the silicofluorides act to increase the leaching of lead from plumbing fixtures. The water chemistry has not been well studied. You make a low pH beverage with this stuff, orange juice, tea, Coca-Cola. You're going to have some other things in there besides free fluoride. There's a very tiny number of studies that have looked at silicofluoride specifically, including one that reported inhibition of acetylcholinesterase activity. But what's important is that the use of silicofluorides is associated with increased blood levels in children, blood lead levels in children, and it's also in animal studies. Silicofluoride exposure has been associated with increased lead in blood and calcified tissues in the laboratory animals, and this is not the plumbing fixtures in this case. A few years ago, Washington, D.C. found increased lead concentrations in water and in children's blood. The CDC failed to respond. There was a congressional investigation of a cover-up by the CDC. But the probable reason for the lead problems, and the probable reason, my guess, as to why CDC didn't want to talk about it out loud, was because it implicated the fluoridation chemicals. So I mentioned the standard for lead and arsenic in drinking water is 0. The enforceable standard is a little bit higher than that, but the fact that any is getting added is just not real good. Okay, this graph summarizes some of the no-effect levels in humans. This is the ranges of intake in different age groups. Again, the log scale of intake of fluoride, milligrams per kilogram per day. This is just from tap water at 1 milligram per liter fluoride in the drinking water. This is the 0.05 to 0.07, so-called optimal. Increased risk of bone fracture, neurotoxicity, severe dental fluorosis, stage 2 skeletal fluorosis, impaired glucose metabolism, impaired thyroid function, moderate dental fluorosis, impaired thyroid function in the case of iodine deficiency. And these are not very solid no-effect levels, but based on the information available to me at the time, And this means that you have to keep the exposures below this, the average exposures for the population below this, to keep most of your population from not having these effects. There is no margin of safety in these estimates, okay? That would bring it down more, but that has to be considered in actually setting a level to use. Significance for public health. Fluoride exposure ranges necessary for many adverse effects of fluoride are reached by people in the United States. The primary exposure for most people is fluoridated drinking water. You've got 11 to 17% of the adult U.S. population with chronic kidney disease. These people will not excrete fluoride normally, so they build it up faster. They are therefore probably subject to adverse health effects from fluoride exposure at lower fluoride exposures or sooner, or both. Iodine deficiency and calcium deficiency are both increasing in the United States. We've got, the CDC already reports that 40% of U.S. children have dental fluorosis. Close to a quarter of the adult population of the country has doctor-diagnosed arthritis. Half of the adults over 65, it's the leading cause of disability in the U.S. Nobody has looked at how much of this might be attributable to fluoride exposure. 4 or 5%, some of these numbers may be a little low because they aren't all quite current, but 4 to 5% of the population with thyroid disease of some sort, diabetes mellitus, we're talking 20 million adults in the United States. There's some indication, again, it's not been well studied, that around 1% of the population might be hypersensitive to fluoride. In other words, they experience fluoride intoxication at much lower exposures than most people. This manifests as GI effects, gastrointestinal upsets, can be skin problems, fatigue, some other things. So substantial numbers of the population, if only a fraction of these are caused by fluoride, we're still dealing with hundreds of thousands or millions of people. The apparent benefits of fluoridation are small. I showed you the best that we have produced is the best studies we have say about a 20% decrease in decayed missing fill, teeth, or surfaces. It's probably an artifact of delayed tooth eruption. It's probably temporary, seen only at the younger ages. The costs of fluoridation are not fully accounted for by a long stretch. They do not include treatment of dental fluorosis. They do not include the costs of hip fracture, which hospitalizes many older adults, and in some cases that's, they don't come out of the hospital. Osteosarcoma, those costs are not included. There's no margin of safety. The range of current fluoride intakes overlaps the effect at which adverse effect levels are seen. What's very important, I think, the children or the populations who are considered most at risk for caries are not helped by fluoridation. There's a number of studies, most of them not very good, but what studies we have show no benefit of fluoridation at helping the at-risk populations. And what is generally not considered is that these at-risk populations might also be the most vulnerable to adverse effects because they are most likely to have the dietary deficiencies and such that seem to go along with these things. Okay, in terms of drinking water standards, what I've referred to as a risk-based approach, the general approach normally for most contaminants is to identify a no effect level for all the known and anticipated adverse health effects. And in some cases, for some chemicals, that's not very many health effects, but the more information you have, the more adverse health effects there often are on your list. But we identify the most sensitive adverse health effect. We try to determine an appropriate margin of safety that will protect the health of the children, the pregnant women, people with pre-existing health conditions, the elderly, all of these susceptible groups, determine an appropriate margin of safety to protect these, and to set what's called a reference dose at an estimate of exposure, daily exposure to the human population, including the sensitive subgroups, that is likely to be without an appreciable risk of harmful effects during a lifetime. And then you set the drinking water standards so that nobody exceeds the RFD. If you do that for fluoride, if you set the maximum contaminant level goal, this is the health-based standard. This is not enforceable. This is the ideal standard. It's supposed to be set at a level at which no known or anticipated adverse effect on the health of persons occurs and which allows an adequate margin of safety. For fluoride, the MCLG should be 0 to protect against the carcinogenic effects, the mutagenic effects, which I really didn't mention, to protect against these other effects. Now, the enforceable standard, the maximum contaminant level, that can be set a little higher. That allows them to consider other things like the cost of removing a contaminant, whether it's feasible, or the cost of replacing the drinking water source. For fluoride, this should be no more than 0.1 or 0.2 milligrams per liter, and this would have to do with the cost of removing it or of replacing the water source. There's no justification for actually adding it to the water supply in terms of the effects that we know about on health, in terms of the exposures that we know are going to result. So that's where a risk assessment approach gets you on the subject of fluoride. And again, I want to thank you for the opportunity to discuss this with you today.
Thank you.
Oh, I need to.
Thank you, Kathleen. We really appreciate your research. The AGD code for this presentation, if you take out your AGD